So I am Quinn. I'm a professor in the Department of OBGYN at NYU, and I've been a member of the Oncofertility Consortium since its inception. And I'm very pleased to present today Dr. Marleah Kruzel. She is a professor and speaker in healthcare communication, and her research focuses on communication of genetic risk information. She's been published in numerous peer-reviewed journals and funded by the National Cancer Institute, the American Cancer Society, the CDC, and PCORI. She's the daughter of a 28-year-old breast cancer survivor and a BRCA2 previvor herself. She's committed to patient engagement in science, and she's also a scientific advisory board member for the nonprofits Force and My Faulty Gene. So I'm very pleased for Marleah to join us today, and there'll be time for questions at the end. You can either unmute yourself and ask, or you can put your questions in the chat. Thank you.
Great. Thank you so much, Gwen. I really appreciate that introduction. Well, good morning from Tampa, Florida. It's a pleasure to be joining the Oncofertility Consortium again. It's been a few years since my first presentation, so thank you for having me back. The goal of this specific webinar is to provide you with a psychosocial map for supporting patients in their healthcare journeys, particularly as it relates to family building and communication of genetic risk information. And I'm also going to provide throughout the presentation some specific evidence-based communication tips and tricks to help you support your own patients and their partners as they navigate these difficult conversations and decisions. But before I begin, I'd like to just briefly note that I don't have any disclosures, and I would also like to acknowledge that portions of this presentation were funded by these different types of sources. So when I was 8 years old, my mother found a lump. It was a tiny lump, barely even noticeable, but I watched her undergo surgery on her left breast, then chemotherapy and radiation, and then later a prophylactic mastectomy on her right breast, and then finally reconstruction. So from a young age, I assumed I would get breast cancer. That's what happened to the women in my family. During their careers, their families, their hobbies, they battled breast cancer. Now, following my mother's diagnosis in 1997, her younger sister then fought breast cancer. And then we learned that my grandfather's mother, Minnie, on the far right, died of breast cancer. My childhood experiences propelled my desire to give back to the medical community who saved my mom's life. But when I was 25, and while I was working on my PhD, I decided to undergo genetic testing. I wanted to know if I was genetically predisposed, like my mother and her sisters, and probably my great-grandmother, to develop hereditary cancers. After I tested positive for a pathogenic variant in the BRCA2 gene, I began surveillance, rotating between breast MRIs and mammograms every 6 months. I quickly realized I was overwhelmed with uncertainty, my uncertain future, and what it would bring. And although I was experiencing uncertainty, like a good researcher, I wanted to know if others were experiencing the same things. So I thought, this is great. I'll conduct research with patients with hereditary cancer risks, but who have not been diagnosed with cancer, so that I can help them, but hopefully in the process, help myself as well. That was over 10 years ago. I now weld my role as a professor, researcher, patient, and speaker to understand and improve communication of genetic risk information between and among patients, their families, and clinicians. In other words, my work focuses on how effective communication can impact health experiences, health decisions, and ultimately health outcomes by developing specific interventions and tools. Now, my work is personal, as you just heard, so I'm very committed to patient engagement. I work with several different nonprofits, Force, My Faulty Gene, and iCare, an inherited cancer registry that offers free case conferences once a month for clinicians and healthcare providers. I'm also committed to science communication, sharing research with the public. So for example, in 2017, I gave a TEDx talk, and in September of this last year, I wrote an op-ed for the Miami Herald. I also frequently give community presentations and am a guest on podcasts. So with all that background in mind, let's jump in and talk about communication of genetic risk information in the context of hereditary cancer syndromes. Now, as you may know, in the last decade, genetic testing has increased, and this has led to identifying individuals who are more likely to develop cancer because of inherited gene changes. Now, this is important because understanding one's genetic predisposition enables individuals like me to make informed health decisions, such as actively looking for cancer in our bodies, preventing cancer through risk reducing surgeries, and even personalizing treatments to reduce their risks and improve health outcomes. Research estimates that up to 10% of cancers may be caused by inherited gene changers. So, for example, the most common hereditary cancer conditions are hereditary breast and ovarian cancer syndrome, so about 1 in 400 people, and Lynch syndrome, 1 in 279 people. Now, there are lots of different inherited mutations which increase cancer risks, but the most famous one, as you probably heard, is BRCA1 and 2 due to the Angelina Jolie effect. So, for example, with my inherited mutation in the BRCA2 gene, they estimate that I have between a 55 and 69 lifetime breast cancer risk in comparison to the general population, which is a 12% risk. But again, that demand is increasing. Genetic testing is continuing to increase. So too will the need for decision-making guidance and support for this population. So what is this population I'm talking about? The term Previvor was coined by the national nonprofit Force, which was motivated by a need to not dismiss the significant ongoing stress and complex decisions that we face as individuals, thereby recognizing us as survivors of a predisposition to cancer. In other words, while previvors face a level of certainty that their risk for developing cancer is very high, we also live with chronic uncertainty about that risk, not knowing for sure if we will develop cancer, and if we do, when that might be that we will develop the disease, as you see here in this quote. But life with hereditary cancer risk doesn't just start with genetic testing. As a part of a randomized control trial with Dr. Tua Pal at Vanderbilt University and Dr. Debbie Cragen, who's also at my institution at USF, we developed several different resources, including an interactive game to help simulate and help patients and clinicians understand what it's like to live the Previvor healthcare journey. Now, this slide that you see here isn't the full game, but I think the visual captures a Previvor's healthcare journey. Again, it doesn't just start with genetic testing, testing positive. It starts when you understand and you start exploring your family history of cancer. And then you start seeking healthcare providers' advice. Maybe you talk to your insurance company about genetic testing and counseling coverage. And then you receive your genetic test results. That could be positive or negative, or perhaps even a variant of uncertain significance. And then there's coming to terms with your genetic predisposition, coping, making cancer risk management decisions. And then, of course, sharing positive genetic test results with your family members. And finally, continuing to manage one's cancer risks across the lifetime, with, of course, the goal being to survive and hopefully not be diagnosed with cancer. In short, a key underlying factor for Previvors' healthcare journeys is uncertainty. Uncertainty exists when a situation or information is probabilistic, ambiguous, or complex. Probability refers to the likelihood of a future event or outcome. So in the case of a BRCA positive patient like me, that might be the likelihood that I would develop hereditary cancer in my lifetime. Ambiguity refers to the conflicting evidence or the evidence's strength or lack of information. So, for example, for maybe newer and less understood inherited gene mutations like ATM or CHEK2, a patient here may experience ambiguity when she finds a lack of clear guidelines for cancer risk management for her specific inherited mutation, and how that might conflict with maybe information she's found on social media. And then complexity. Complexity refers to the many different factors and interpretations that make an event or information difficult to understand. So let's say you have a PALB2 positive patient. They may experience uncertainty after learning their positive genetic test results, but there's no cancer diagnosis in her family, so there's no context. In the case of Previvors, research, including my own, supports this notion that risk-related uncertainty is inherent for Previvors, it's more intense, and it's experienced chronically. More specifically, my work has found that Previvors experience medical and familial uncertainty. Medical uncertainty encompasses the unknown future, engaging in those surveillance appointments, and personal cancer scares. So, for example, I vividly remember my first breast MRI. The technician's cold hands, the flickering lights, the loud sounds, my numb arm where the IV was, but more importantly, my inner struggle with myself. What if the cancer is there? What if they find something suspicious? What if? But familial uncertainty includes remembering and reliving traumatic family cancer memories, as well as making decisions about motherhood. I'm no strange to this uncertainty either. You've already heard how my mother's breast cancer diagnosis impacted me as a child and inspired my career. Yet, in addition, when my husband and I decided that we wanted children, we had several difficult conversations about how to build our family, something I'll talk more about in the presentation later. But I also want to highlight a newer source of uncertainty that I'm exploring with some colleagues at WashU, and that is financial uncertainty, the financial burden of cancer risk management decisions and follow-up care. So the problem arises when uncertainty is left unmanaged. Unmanaged uncertainty has detrimental effects, including poor decision-making, potentially increased cancer diagnosis, and mortality rates. In fact, some studies have actually found that previvors face more psychological distress than even patients diagnosed with cancer. So how do you manage that uncertainty? Uncertainty management involves making specific choices based on the perceived threat. So in this case, a future cancer diagnosis, and the available information, in this case, positive genetic test results, and then recommended cancer risk management decisions. And according to uncertainty management theorizing, we know that information helps previvors manage their uncertainty by increasing their knowledge and sense of control. Now, one way that previvors manage their chronic uncertainty is by making those cancer risk management decisions. So in one study, I interviewed almost 50 BRCA1 and 2 previvors to really understand how they made these difficult decisions and how that managed their uncertainty over time. So for previvors who assess their uncertainty as a danger, they chose risk-reducing surgeries, which reduced their uncertainty about being diagnosed with cancer in the future. And it also reduced their distress and improving their psychological well-being. So for example, one previvor summarized this when she said, "I don't have to worry about getting cancer every day." On the other hand, previvors who chose surveillance initially assessed their uncertainty as an opportunity. Now, that did reduce their distress at first, but then it required management over time. These previvors continued surveillance and they ended up having to reassess their uncertainty as a danger, mostly due to those distressful triggers like waiting for biopsy test results or making family planning decisions. Another previvor said in an interview, "My main thing is that I want to have a family." And so this led previvors to constantly having to manage their ongoing uncertainty across their lifespan, which has also been my experience too. Another previvor remarked, "I'm gambling that I can live my life happy enough for a few years, or as many years as I can push it. And I pray to God that I don't get cancer." Now, another way to manage previvors' uncertainty is that we engage with our healthcare team. And we do that in 3 ways, my research has found. Number one, seeking our healthcare team as an informational source. So finding knowledgeable clinicians who are willing to discuss information from a variety of different sources. Seeking our healthcare team as partners for decision making, partnering with a physician who helps us make those difficult decisions for cancer risk management. And then finally, seeking healthcare team members who help us with emotional support. A physician who listens, provides support and empathy, who tries to understand our life situations and experiences. But then also someone who provides us with referrals to other healthcare providers when our uncertainty is too much to handle or additional support or therapy or counseling might be needed. Now, taken together, all of these studies really highlight Previvors' complex decision-making processes and demonstrate that interconnectedness between uncertainty management, information, and decision-making. Yet, healthcare providers and clinicians are not the only source of uncertainty, an only source of information, that Previvors utilize when navigating their healthcare journeys. I'll briefly share some information from another study that a former PhD student and I conducted. And we surveyed 101 previvors, and we were really trying to understand what barriers previvors face when they're seeking information and the different types of information sources they utilize. And for the sake of time, I'm just going to focus on one, which was one theme, which was healthcare systems in general. Our survey participants reported how the healthcare system often hindered their information journey. And there were three specific subthemes that acted as obstacles. So first, previvors expressed that because there's no centralized source that they can turn to for uncertainty, it often felt like the healthcare system at large was impeding their ability to find information. Second, previvors also reported that sometimes their clinicians and their providers lacked knowledge about hereditary cancer risks in general. So, for example, one participant wrote in a response and said, I lost faith in my primary care physician for not knowing even basic information about how to proceed. Last, previvors shared that they faced challenges about insurance coverage. One participant wrote, it's a little confusing to figure out how much screenings cost and what's covered by insurance. So understanding visits, testing, procedures, and what was covered by insurance was another major concern. Now, as you can see here on the right, previvors were drawing on a variety of different information sources as they navigated their healthcare journey. Clinicians, of course, but also family members and friends, social media, other previvors with similar lived experiences. But what I think this study highlights is that the healthcare system itself is creating uncertainty, and it ultimately places burdens on us as previvors as we're trying to navigate our healthcare journeys. So far, we've discussed previvors' personal health decisions as it relates to cancer risk management. But as previvors, we also have to make family building decisions. And family building is the act and process of decision making about children. So, timing, method, approach, the number of children that we want. And previvors and their romantic partners have unique challenges and concerns when we're making these decisions. So, for example, couples may be concerned about their inherited cancer risks for future offspring, as carriers have up to a 50% chance of passing on their pathogenic variant to each future offspring. Additionally, previvors, we have to navigate that cancer risk management decision, such as undergoing a risk-reducing surgery, which can have implications for family building, such as not being able to breastfeed. And then, of course, patients' culture, religious beliefs also impact our decision-making too. For example, when we're considering assisted reproductive technologies. So in short, in this context, family building is difficult and complex and takes a lot of time. Yet most of the research in the hereditary cancer context has really focused on cancer risk management decisions rather than the balance or the negotiation that goes on between personal health risk and family building. And so I want to kind of dive into this a little bit deeper and show you some results from one specific study my colleague and I, Dr. Rauscher, and I conducted, where we were really trying to understand how previvors make decisions regarding family building after they tested positive. So very briefly, participants were mainly recruited through force, and we analyzed and conducted interviews with 20 female BRCA1 and 2 previvors. And as you can see here, we talked about a lot of different things, but really focusing on family building desires and preferences and how they communicated about that with others. We analyzed the data using the constant comparison method through developing a code book and several iterations. So overall, we found that when previvors are making these family building decisions, that we enact logical and emotional decision-making styles. So specifically, previvors consider undergoing those risk-reducing surgeries in a logical time frame as recommended by National Comprehensive Cancer Network guidelines, as well as their different clinicians they interact with, but also keeping in mind their emotional desires to be mothers and often have biological children and breastfeed. So let me show you some examples from our data. So logical decision-making style, this really involved two different dimensions. So timing and timelines for undergoing those risk-reducing surgeries, and then pressure from clinicians and healthcare providers. So for example, here, Callie, she's sharing how she and her husband discussed the ideal timing to have a prophylactic bilateral mastectomy, as well as her second child, and weighing all of the different options. Additionally, Previvors also reported in this study that their providers oftentimes had strong recommendations on having those risk-reducing surgeries and when to have children. So Brooke, in her interview, she recounted how her clinician really advocated for her to undergo a prophylactic bilateral mastectomy before trying to have a baby. She shared that her doctor said, as she remembers it, I want you to do the mastectomy because what's going to happen is that we're going to inject you full of hormones. You're going to get pregnant and you're going to have 9 months of hormones, and then you're going to be sitting in chemo when your child is 2. And then there was emotional decision making, and that involved 3 different dimensions: biological time clock, passing on an inherited gene mutation, and then hope for the future. So, for example, Christy, when talking about that first dimension, she shared, I just hated closing that door. I hated to lose my fertility. Losing my breasts was a lot easier than my ovaries. Losing my ovaries meant a lack of hormones, a lack of fertility. It was just difficult. I wanted to squeeze everything out of them that I could. In terms of passing on her inherited gene mutation, Corinne shared with us when she saw the positive pregnancy result that she immediately thought, my God, what have I done? Am I a bad mom? And then last, Previvors also mentioned and emphasized their hope for the future, which was really a rationale for prioritizing their family building over personal cancer risk management. Molly shared with us, we'll have lots of solutions by then. The solutions that are already available now are even better than they were 20, 30 years ago. And so by the time my kids are old enough to really have to worry about hereditary cancer, hopefully we'll have even better solutions and options for them. So in short, this logical decision-making really prioritized decreasing their personal risk for hereditary cancer and thus undergoing risk-reducing surgeries over having more or any children to begin with. While the emotional decision-making style really prioritized having children by often extending their surgery timelines and in so gambling with their personal hereditary cancer risks. So based on this research study, as well as some other studies I've conducted with Previvors and their romantic partners, how can we help Previvors and their partners? And here are 3 specific communication tips that might be helpful that you can share with your patients in consultations. Number 1 is to select a dedicated time to discuss family building options and preferences without distractions. Most of these conversations happen haphazardly, randomly at the dinner table, prepping for the meal, in the car, taking a walk. And so finding a time and place that works best for the previvor and their partner will really help facilitate this conversation and make it more effective. Participants also emphasized in another study that this is not a one and done conversation, that it's going to require likely multiple conversations over time. And that's possible, right? Because previvors have time. It's an increased risk for hereditary cancer, not a cancer diagnosis. Second, I encourage you to encourage couples not to assume they're on the same page. While many couples might share that they know what their significant other's preferences and desires are for family building, our research has actually found that they may not be on the same page, that there might be key differences in how and when they want to build their families. So simply pointing this out to them and not having them assume and ask their partner for what their preferences and desires are will also help facilitate these conversations and ultimately assist in decision making. Finally, help them create a game plan between you, the patient, and the romantic partner. Again, these conversations can be difficult. The decisions, as I just described, are very complex. But creating a game plan, as one patient called it in our study, means that you're creating a shared understanding about having children, which again could encompass timing, method, approach, number of children, and will ultimately help the couple navigate their uncertainties about family building. To further facilitate effective communication about family building between these couples, my colleagues and I, including Dr. Quinn, who introduced me, we created the Caring tool, which was a theoretically informed multi-stage decision support tool for couples. And if you're interested in that, you can actually go back to the first webinar I gave for the Oncofertility Consortium back in March of 2023. So I'm going to switch gears now and transition to adolescent young adults, the AYA population, and those who have been diagnosed with cancer for the second study I want to talk about. And the AYA population, as you likely know, but to make sure we're all on the same page, is between 15 and 39 years old. And family building is also a concern for the AYA cancer patient population for several different reasons. For example, cancer treatment can impact patients' fertility, even cause sterility, and thus impact cancer diagnoses and associated treatments on future fertility. Second, these concerns also often coincide with the patient's fears about genetic risks for their future offspring, much like Previvors. And the National Comprehensive Cancer Network recommends that patients of reproductive age should be counseled about fertility, genetic risk, and reproduction. So the other study I want to share with you today was really trying to understand AYA cancer patients and their healthcare providers' discussions and concerns about genetic risk and family building, as well as what their preferences are for educational materials. Again, very briefly, our participants were recruited through a cancer center. We had a total of 17 AYA patients who participated in interviews, as well as 18 healthcare providers. A variety of different providers were interviewed, as you can see at the bottom of the table here. And the average age for our AYA patients was 32 years old. We analyzed the interview data using the constant comparison method and specifically MaxQDA, which is a computer-based qualitative data analysis program. So I want to walk you through the three different themes we identified. So first, while patients in our study reported that their understanding about fertility and genetic risk information revolved around how their healthcare providers communicated these complex topics, many patients were unsure or uninformed of the hereditary nature of their cancers and even the subsequent impact that it could have on their future children. So, for example, one patient shared, "I did not know anything about my father's background." Additionally, many healthcare providers indicated that there's a lot of complexity and in terms of the information and volume that you have to share with your patients. And so that really limits their understanding or can limit their understanding. As you see here in this quote, this provider is noting that while providers are aware that they need to consider their patient's health literacy level, it can be really difficult to explain these complex issues that are understandable. Second, healthcare providers and patients also reported differences in the information provided regarding fertility and genetic counseling and testing. About half of the patients in our studies reported that the provider had actually never discussed family building or genetic counseling and testing. One male patient emphasized there were no conversations about it at all. In contrast, our healthcare providers reported that they were explaining these issues, but they also acknowledged that sometimes these conversations would happen after treatment. And that was problematic because it really reduced the relevance and the utility for the patients themselves. Many providers were also surprised that their patients were unaware that their cancer treatments could even impact their fertility. And furthermore, some providers in our study shared that some patients would actually initiate these discussions about genetic risk for future children, while our patients expressed that the providers did discuss fertility. It was only happened when they brought it up themselves. Finally, patients and providers had different preferences for educational materials. Patients mainly suggested that they wanted more information about IVF, in vitro fertilization, sperm banking, and genetic risks for children in general. On the other hand, our healthcare providers noted that the information should really be focused on genetic risk to future children. Now, both providers and patients did agree that face-to-face interactions were really their preference for having these difficult conversations, but that it could also be helpful and valuable to have educational packets that were tailored to the specific AYA cancer diagnosis and the treatment. And finally, both suggested that there was really a need for materials for caregivers and spouses of AYA patients. So overall, AYA patients in the study reported that family building and genetic counseling and testing were often not discussed, or that they did not recall that discussion. Previous research has actually found that healthcare providers are sometimes reluctant to discuss family building because they don't want to add another level of complexity or stress to already difficult decisions. And so that might be why patients in our study were actually initiating those conversations. But given the discrepancies that we identified between patients and providers' perceptions of their information needs and conversations, we think it would be valuable to implement a multidisciplinary approach in clinical practice, where patients are being exposed to information about family building and fertility and genetic risk at multiple stages throughout their patient journey. So with that in mind, I want to offer some practical tips for providing this fertility and family building decision making, again, based on our findings. So what should you be sharing? Obviously, the different family building options that exist, sperm banking, egg freezing, embryo freezing, and again, as early as possible in the healthcare journey, including including clear information about genetic risk for future children. How should you share this? Well, in our study, as I said, patients really expressed the importance of tailoring that information to their situation and discussing it in person in consultations. But patients also talked about a need for testimonials or stories that would really depict patients, who they could relate to and understand their feelings and experiences. And so I wanted to highlight a resource that the nonprofit My Faulty Gene has created. It's called the Family Gene Share. And this is a collection of video patient testimonials that are really talking through genetic testing and how genetic testing information can impact the family. Providers also suggested having specific communication tips and strategies for helping patients manage their uncertainties and make these difficult decisions. And so a slide in a minute will also address that too. But last, I wanted to talk about who to share with. And again, patients and healthcare providers in our study really emphasize that information should not just be for the patients themselves, but also caregivers, partners, and family members. So again, keep in mind that patients' decision-making process, whether we're talking about AYA cancer patients or Previvors, their decision-making process is influenced by communication between their healthcare provider and, of course, sometimes their partner too. We all have predisposing influences, such as our own communication styles, our attitudes, our values, our beliefs. And all of these things influence our decisions and our perceptions. Our emotions play into these and ultimately impact our decisions. So what I encourage you today is to see communication as a tool for improving healthcare decisions. So from this perspective, here are 3 evidence-based communication tips for you as healthcare clinicians and providers. First, and you already know this, but I want to call it out. Patients, we use the internet. We use social media to find information. So instead of shying away from it and not talking about it, teach patients how to critically evaluate the information and identify credible, quality information that is accessible and helpful to patients' goals. Number 2, provide information and emotional support across our lifespan. Yes, actively listen, provide resources when there is a cancer diagnosis or when a patient receives positive genetic test results that increases their risks for hereditary cancers. But also check in on patients across time, times such as increased surveillance where emotions are triggered or uncertainty arises, or when a family member is diagnosed with cancer and brings up a lot of experiences and lived memories. And again, if you feel out of your capacity, maybe you don't have time or you don't feel the self efficacy to be able to have these conversations with patients, then refer patients to get the emotional and mental help that might be needed. Finally, engage in shared decision making. Decision making needs to be a collaborative process. Patients want to make informed health decisions with providers based on credible information and the best scientific evidence, but we also have different values and preferences and needs. So, for those of you who might be creating resources or programs, maybe educators on this webinar, for patients and particularly previvors, I put together this list for specific unmet needs for previvors based on the literature that I think is really essential as we help previvors across our healthcare journeys. Again, specific information tailored to the inherited cancer risk that the patient has, information that is easy to understand and it's accessible. Psychosocial coping, both within the clinical consultation, but also outside of it, so that when emotions and uncertainty hits at 2 a.m., that we can really manage it. Sharing genetic risk information with family members and clinicians over time. And then seeking care for that cancer risk management across our lifespan and how it's intertwined with family building decisions. I think what's really important here is that any patient resource, any intervention or tool, it should not only empower patients with information that's credible and up to date and provides social support, but it also enables us to have skills that we can replicate with other healthcare providers and even our family members as we navigate our complex health journeys. In conclusion, there are days that, of course, I wish I had tested negative, but I am a previvor with uncertain future, and I choose to embrace this part of my identity, striving to help others while continuing to challenge myself. I choose to embrace my uncertain future and follow my mother's very wise words and make the best decisions I can with the information I have at that time. Anytime I give any talk, I also provide valuable resources for patients and clinicians. This is just a collection of a variety of different hereditary cancer nonprofits, podcasts that might be helpful for you and your patients. I, of course, want to thank all of my co-authors and team members. I wouldn't be able to do any of this work without them. Here are some references, the main references, and I'm happy to share any additional references if you're interested in. And I would love to connect with you. You can follow me on LinkedIn. That's my social media platform. I also have a YouTube channel as well. And then the last thing before I turn it over to the Q&A, which I'm really excited about, I wanted to invite you and your patients to a webinar series on Previvors perspectives. So on Lynch Syndrome Day, we're going to have a live conversation with Dr. Tua Pal and Katie Lang and about living with Lynch syndrome risk. And the goal here with my webinar facilitator, Sarah Kavanaugh, is to bridge this gap between clinical guidelines and guidance and living every day with hereditary cancer risk. So I hope you will share this with your patients, and I look forward to your questions. Thank you so much.
Thank you, Marleah. That was amazing. Lots of positive congrats to you in the comments. While people are potentially unmuting and thinking about their question, there's two questions that came in.
Okay, great. Hold on. I can't see everybody, so let me stop sharing so that I can see everyone.
Yeah. So one was in the chat to everyone, one was in the chat directly to me. So the
Okay,
one in the
great.
chat to everyone was from Dr. Klosky, who's specifically asking about the first study with the N of 20, whether or not previvors were aware of contemporary family building ART options, specifically
Yeah.
like PGT.
Yes, that is a great question. And thank you so much for that question. So in this sample, yes, there were some previvors who were familiar with in vitro fertilization and the options for doing PGT, and there was some that were not. Again, it's a small sample, so keep that in mind. For the people who were aware of those assisted reproductive technologies, in general, most of them really weren't interested in that due to financial costs and concerns related to that. There were some concerns about religious beliefs regarding playing God. I remember one quote from an interview I conducted with that as well. So, in general, I think there's more awareness nowadays, especially that there are these tools with which we can stop hereditary cancer in its tracks, that it doesn't impact our family trees anymore. But there's still a lot of reservation in terms of these different technologies. Now, for the previvors who weren't familiar with it, it was actually a very interesting situation to be in as an interviewer, right? Because being able to talk about those options. And so at the end of interviews, we did offer some credible sources and information that we could share with the previvor could look into that more specifically. Hopefully that answers your question. Thank you for the question.
Thank you. And the other question was saying there are guidelines, or do the current guidelines, if they recommend that no one take any prophylactic surgical options before age 35, how does that fit with some people being diagnosed with cancers at much younger ages?
Oh, that is a great question, and I am not able to speak to that. I don't know if you can, but not to put you on the spot, but I don't know the answer to that question off the top of my head.
I don't either, and I would say this probably kind of a glib answer is it doesn't fit.
Right.
I do think that those are recommendations, they're not laws. You know, certainly I think surgeons, and especially surgeons who deal in this area, can make their own shared decision making with a patient based on
Right.
family history and age. But I see iPhone 09123 has their hand raised.
Yes, please.
And thank you so much. I have a question. I recently had a patient who was a carrier of the BRCA gene mutation, and she had previously frozen her oocyte. She
Mm.
was now gotten married, but the couple does not wish to use PGT. From an ethical standpoint, can this
Mm.
physician accept this request, given that there is a possibility of transmission to the offspring?
Oh, wow. That is a really interesting question in
Could
terms
you
of
hear
the.
me?
Oh, sorry, what? Yeah, so I think that's a thank you so much for sharing. Yeah, I think that's a really interesting situation. So to make sure I understand, the patient is a carrier of a BRCA1 or 2 mutation, and they froze their embryo, or did you say their eggs? I think I cut out there.
Uh, yeah, her egg.
Their egg.
She
Okay, thank
frozen
you.
her egg,
All
and
right.
she resenting gotten married. Yeah.
Yeah,
Mhm,
so then she got married, but the
mhm.
partner, the spouse, was not interested in PGT. Is that correct?
The couple, both of them doesn't want. They don't want to have PGT to have PGT. They
Okay.
refuse it. I was confused if I proceed the procedure, the IVF, without any PGT or not. I'm confused about it because I know there's this BRCA gene mutation transferred to her offspring. Yes.
Okay. Yeah, no, thank you for clarifying. I just wanted to make sure I understood the question. So, I mean, I would recommend shared decision making, right? I understand the ethical question there. I think within the hereditary cancer community at large, in the research, there are many of us who are carriers who wouldn't be here if our parents had used PGT, for example. And so, hindsight is 2020, of course. In terms of, I think you have to think about, what you are comfortable, of course, but I think ultimately, as a patient myself, I would want my provider to, provide information and talk to me about it so that we could figure out what are, how we could achieve my goals as a patient and the things that I value. So I think there's always room for communication about the different types of options, such as PGT. But I think ultimately, from a patient perspective, I think it's important to value what the patient wants and desires. So that would be my thoughts. Gwen, I know you're an expert in the ethics realm too. I don't know if I can put you on the spot again if you have any insights here as well.
I agree with what you've said.
Thank
I
you.
think it's always shared decision making. And I do know in some, particularly with people who actually have a cancer diagnosis and may have a religious, cultural, often the team can consult with. I know, for example, in many people of various Jewish sects or Jewish faiths, they can consult their rabbi and a kind of a case by case decision can be made for them.
Uh-huh.
So yeah, I think instead of just completely closing the door, there's, other people to consult that may help them better with decision making outside of the medical field.
Yeah, absolutely. I think that's really important. I think oftentimes as patients, sometimes it's we don't have the information, right? Like in the PCAF study, some previvors didn't even know that was an option. And then there are other scenarios where, patients, decisions change too, right? So when the patient originally froze her eggs, maybe she thought something then, and now, they think something differently now. I think, decisions change with time as life expands. So I think you're trying. It sounds like you're trying to help the patient, which, as a patient myself, that's amazing, and I applaud you.
Yeah. One more question asking, and I don't know the answer to this. What's the
Hmm.
youngest age that someone can be tested?
Oh, the youngest age that someone can be tested. I
Yes,
don't
to
think
see if
I
they're
don't.
carrier.
Yeah, I don't know the answer to that the youngest they could be tested. I will say, as someone, as I mentioned, I was tested when I was 25, and that was that was very specific because I knew, according to our National Comprehensive Cancer Network guidelines in the United States, that was at the age that I could start screening. And so that was why I waited until then. Um, it's a common question I get when I am doing patient facing talks from parents, at what age should I get my children tested or not? And of course, we've got, ethical implications there as well. Um, I think it's really important that children are aware of what's going on. I mean, I wouldn't be sitting here in front of you today, if I hadn't been that 8-year-old who lived in hospitals for 5 years. So I think it's important that we're open and we're honest with our children. But ultimately, from my perspective, I mean, it should be an individual's decision. It should be the patient's decision. And I think the last thing I'll say too is that oftentimes in the genetic testing world, and the hereditary cancer world as well, we assume that genetic testing is going to provide us with information and empower us. And I agree with that. I think that's all true. But as my research has found, genetic testing really just shifts the uncertainty, right? It's you have this inherited cancer risks that then you have to manage over a lifetime. And so making sure you're really ready and there's support around you, and you're aware of the decisions that you can engage in, is really important as a patient, regardless of the age.
Are there any other questions? Feel free to unmute if you do have a question, or again, can put it in the chat. I think I have a question. To what extent in your, maybe your encounters more as an advocate, do
Mm-hmm.
you find people are reluctant to share information within their family, or it's just not part of the culture to talk about, particularly, gynecologic, breast-related things?
Yeah, that's a great question. Yeah, I mean, family communication about genetic risk information, that we could do a whole nother webinar on that, which I would be happy to do at some point. But yeah, I mean, sharing this information it can be really difficult in the family. There were, for example, in the PCAF study, I remember there was one previvor where she and her partner, because I can't remember if it was a spouse or not, they talked about how they kept things quiet, that they didn't specifically share that they were interested in IVF and PGT, because they didn't want their in-laws to know. And so I think when you're talking about, very complex decisions with genetic risk information, that it is really sensitive. There are a lot of different reasons why family communication about genetic risk information is difficult. For one, it's very personal, of course, but then you're dealing with multiple interactants who have different beliefs and values and attitudes. So I think that's why this space is so interesting to me, because it is very complex. I think the biggest thing that we have found so far in the literature, though, is simply being willing in the family, regardless of the family member, being willing to have open, frank conversations about genetics really does help with psychosocial coping and eventually decision making, particularly in the family building space.
Yeah. We see that a lot in studies about men with prostate cancer
Mm-hmm.
being reluctant to share with rather at-risk brothers for a variety of reasons, either because they've never had good communication about anything, or just kind of the personal nature of the cancer, or to even
Yeah.
talk about cancer.
Yeah, exactly. We don't often have the language to be able to talk about that and how it impacts us. So I think you're right. I think absolutely there's been research to suggest preparedness, or our perceptions of our own self-efficacy. Can we even communicate the information about our inherited cancer risks to our family members? That's really difficult. So I think there's an element of understanding and health literacy, which is kind of what that second study was getting at. And then oftentimes, information changes, information evolves over time, and so that makes decision making even more complex too.
Uh, yeah, years ago when I was still at Moffitt and working with Susan Vadaparampo,
Mm-hmm.
we're looking specifically at risk among people with Hispanic Latinx backgrounds.
Mm-hmm.
And so many people would say, I know my mother died of cancer, but she referred to it as cancer down there, or female cancer, without any types of specifics. And
Mm-hmm.
yeah, it just was very taboo to talk about body
Yeah.
parts and
Yeah.
cancer.
Absolutely. And I think that's really that complexity element of uncertainty, right? So then you as the patient, you kind of know, well, there's something in the family that's affecting us, but we don't quite know what it is. And I don't really feel, our family culture is that I can't ask any questions. So how do I make, informed health decisions for me? So yeah.
Yeah. Well, thank you so much for this talk. This is really interesting as always. You saw that Marleah gave her contact information, so if you want to follow up with her about anything, and this webinar was recorded and will be on the Oncofertility website. So thank you all, and
Great.
if you're in my part of the world, stay warm and dry.
Yes, thank you so much for having me. I really appreciate it. And thank you all for your questions. Please keep in touch.
Bye-bye.